I'd like to thank the organizers for inviting me to give this presentation. It's something that's near and dear to my heart, and I hope I can both inform and provide some interest for you today. So I have a number of disclosures. I heard one speaker say, I wish there were more, because that represents the people that are interested in women's health. So what is a perfect storm? Some of you may not know what the perfect storm is, so I better define that before we get started. Perfect Storm was a movie about a confluence of adverse weather events. So there was a hurricane, a high tide, full moon, and a fishing boat called the Andrea Gale got caught in the middle of all this, and it sank and killed the crew. And it became quite a famous movie produced based on a true story. So I'm going to talk about the confluence of events that really affects our perception of breast cancer and breast cancer risk. So first of all, what factors influence our perception of risk day to day? So is it natural or artificial? We don't mind going out in the sun, although we know it causes skin cancer, but don't put us in a building with asbestos in the walls, right? That's not our choice. Smoking, yes, people know that's risky, and they'll go mountain climbing, but they're very concerned about somebody else slipping pesticides into their food or nuclear power plants over which they have no control. And then we always evaluate benefits, right? We're willing to take some risk. There's a risk in driving a car, but it saves us a lot of time and gets us around. Probably most important is personal contact with somebody that's had the condition. I've seen women in my menopause clinic where the mom had bad osteoporosis and fractures, and they want hormones no matter what I say to them. And then there's the woman whose girlfriend had breast cancer, and she doesn't want to touch it because she's been so affected by this personal contact. And then it's important for us to know that risks need to be compared with other risks, because we may think a risk is really big, but then we realize we're accepting other risks that have much greater impact. So Malcolm Gladwell wrote an interesting article that really kind of set the stage for this presentation. He talked about a number of factors, and the one he talked about was the historical perspective. So the thalidomide tragedy, where there was thousands of people born with phocomelia, the short limbs. Rachel Carson wrote Silent Spring about the hazards of DDT. And there was a 1959 cranberry scare where aminotriazole was said to be very toxic in cranberries. And then people realized that cabbage has 20 times that amount, and we eat lots of cabbage. So historical perspective was that synthetics and big business were dangerous. They're trying to adversely affect us. And Ralph Nader was the leading crusader who took on the auto and the nuclear industries. He actually convinced baby boomers that synthetic chemicals and energy were dangerous. The companies selling them were powerful, reckless, and irresponsible. And I liked his comment on food additives. He says, nitrites and wieners make them among America's deadliest missiles. So we've developed a cancer phobia, and it's been enhanced by the fact that our technology now allows us to measure parts per billion. So you've seen reports about saccharin and red dyes and Aller. I'm going to tell you the Aller story because it's very instructive. Ed Bradley on the news show in the United States, 60 Minutes, did a presentation on Aller and said it's the most potent cancer-causing agent in the food supply today. It's something that's sprayed on apples to keep them on a tree a little longer till they get red. And there was panic within 24 hours because millions of people watched this show, and one elderly lady called the Environmental Protection Agency, said, should I pour my apple juice down the drain or take it to a toxic waste dump? Now, just to show you how ridiculous that is, this cost the American apple industry $100 million, and the equivalent dose to replicate the dose that was tested in mice is 28,000 pounds of apples per day for 70 years. So we can be fooled about risks based on the way things are presenting. And Larry Lawden, in his book on risks, says underestimating common risks and exaggerating exotic ones, we end up protecting ourselves against the unlikely perils while failing to take precautions against those most likely to do us in. So what are the big risks? If you look up what the big risks are, they're driving a car, boating, drowning accidents, smoking, drinking alcohol, and household chores. Many women are injured standing on a drawer that they've pulled out to reach something high on the counter. But what's the public worry about? I'm not going to read through this list. It's all well known to you. But down at the bottom there is menopausal hormone therapy. It's one of many, many things that the newspapers have generated anxiety about. Scientific American, prior to the release of the WHI, had an article on hormones. And this quotation is still true today. It says, "It's largely fear of breast cancer that fuels the debate about hormone therapy." You know, if there was no concern about breast cancer, everybody would be taking it. So the first thing in our confluence of effects is this fear and suspicion of corporations and synthetics. Then there's the media hype about hormones and breast cancer. I was flying in an airplane to New York City, and I came across this article in 2000. Now, how can you imagine being a layperson and seeing this title, "When Estrogen is the Villain"? It gets imprinted in your brain. And when WHI came out in 2002, there were scary headlines. This is my local paper in Kingston, Ontario. "Hormone therapy, more harm than good, causes heart attacks, cancer, Alzheimer's," on and on and on. And the reality is, for many family physicians, this is the first information they had about this, actually for many specialists as well. And it really was an issue. Now, the WHI, as you have heard many, many times, and I won't go into it in great detail, they had to make a compromise. They didn't want to do the ideal study. The ideal study would have been to take 250,000 50-year-olds and randomize them to placebo or treatment and see what the impact was 35 years later on breast cancer and heart disease. But that far too expensive, would take far too long, and not many 50-year-olds with bad hot flushes would agree to be randomized to placebo for 35 years. So they made a compromise, and they accepted women up to age 79. And the tragedy was that 2/3 of the women in that study were over age 60, and they were not representative of the typical woman to whom we prescribe hormone therapy. And the headlines came out, they were quite alarming. There's a 26% increase in breast cancer, 29% increase in heart disease. But if you read the paper very clearly and see what the WHI study actually found, the 74% of women who'd never used hormones before showed no increased risk of breast cancer on combined estrogen and progestin therapy. Women on estrogen had no increased risk. And when they did their subsequent analysis 5 years later on cardiovascular disease, younger women actually had a reduced risk. I wrote an editorial at the time, and I made a comment in regards to the heart disease claim that it increases heart disease. I said, if you put this is a picture of a 79-year-old on a treadmill. If you put a bunch of 79-year-olds on a treadmill and cranked up the speed, there'll be a few of them will fall off and have heart attacks. And you would then assume that exercise was bad for the heart. And it really emphasizes the fact that age is important. And about 2 years after the WHI publication, Hulley and Grady wrote in JAMA, women in their 50s have half the baseline risk of women in their 60s and a quarter of the risk of women in their 70s. So we were evaluating risks in a higher risk population and translating that into management decisions for women in their late 40s and early 50s. And this is the data showing reduced mortality in younger age women in the WHI. So how should we express the risk of breast cancer for women considering hormone therapy? Well, if you look at the actual numbers in the WHI, the breast cancer risk was 30 per 10,000 in the placebo users and 38 per 10,000 in the hormone therapy users. That's 8 more breast cancers per 10,000 women. And to describe that as an attributable risk, it's 0.8% risk per year, less than 1/10 of a percentage point increase per year of use. And that is considered a rare risk by the World Health Organization. But negative first impressions are hard to reverse. Robert Langer, who's with us today, wrote that first impressions are nearly impossible to reverse. Although news release mentioned that the estrogen alone was continuing because there was no indication of increased risk, the impression of harm carried over so that use of estrogen declined rapidly along with combined therapy. And more importantly, when reported 2 years later, the contrasting results of the estrogen alone trial were basically ignored by the media. Bad news sells, good news not so interesting. Vince Convello has said research has shown that strong beliefs about risk, once formed, change very slowly and are extraordinarily persistent in the face of contrary evidence. I still put a toque on when I go out in the winter because my mother told me I'd get a cold if I didn't keep my head warm. And I know that's silly, but it shows you how something that's imprinted in your brain is hard to change despite having better knowledge. So who is responsible for the media frenzy? Is it the media or was it the WHI writing group? And my answer is it was probably both. Dictums of the news world. There's nothing more perishable than news. They have little time for expert review and commentary before going to press. And there's tremendous competition to get the attention of the reader. They've got online, they've got newspapers, TV. And you can see on the right a number of stories there that made headlines. You know, parents mourn child killed by a snowman, teen drops dead playing volleyball, golfer struck by lightning while heading to the shelter. So the old dictum is, if it bleeds, it leads. Bad news gets people's attention. Good news is saved to fill in the space around the advertisements in the newspaper. And the other problem with media is so often associations are portrayed as causal associations. There's a direct association between the number of bars and the number of churches in a city. Does alcohol drive you to drink? Or does drinking make you religious? Or maybe there are just more people and you need more churches and more bars. And the reality is that associations are implied to be causal when in fact they often are not. A recent comprehensive analysis of breast cancer articles in the media found that the news articles were much more likely to focus narrowly on hormones, with little, if any, coverage of other equally important risk factors or preventive strategies. Lifestyle choices that impact postmenopausal health. Well, there's certain things that are too late to change when you're 50, right? You can't change when you had your first birth or how long you breastfed or when your menstrual period started. But Sprague has estimated that 34% of breast cancers could be eliminated by lifestyle changes at the time of menopause, avoiding postmenopausal obesity, alcohol, and various other things. So what role did WHI writing group play in the sensational headlines? Well, according to Robert Langer, there was a pressure from the writing group to deliver a consistent, and I put my emphasis in their negative message about HRT, and they rejected the idea of publishing alternative interpretations of the data. And to quote him specifically, he said the writing group feared publicity, fear, and sensationalism over science. So it was not just the media, it was the writing group and the media together. So we now have competition for attention from researchers and the media. Next thing is numerical or statistical illiteracy, and I think this is the most amazing one to me. Failure to understand basic concepts of relative versus absolute risk. I was called by an editor of a woman's journal when they said there was a 26% increase in breast cancer. And she said, Dr. Reid, does that mean every 100 women you treat, 26 get breast cancer? I said, look, if the risk is 1 in a million and it goes up by 26%, it's 1.26 per million. And so there's this lack of understanding. This is an editor of a journal, and there's publications now saying we need to start teaching statistical numerical literacy in grades 3 and 4, because our kids grow up with very distorted perceptions. And they have unrealistic expectations. The lotteries, someone has to win. It could be you, right? So the websites are legally required to state in layman's terms on their websites what the chances really are. So I looked up 2 of them. Mega Millions was paying out $640 million. Wow, I'm going to run down and buy some tickets for that. And it says if you buy 50 tickets a week, you will win the jackpot every 68,000 years. Don't waste your money on tickets. And Powerball, it says your chances of winning are 1 in 173 million. This is called statistical homicide, the triumph of long odds over common sense. Try this experiment. I actually heard David Grimes do this, and I've done it now in a group of people. I was giving a lecture, and there were 30 people in the room, and I said, if I can tell you how to increase your chance of winning the lottery by 100%, would you pay me $1? 10 hands went up. I said, well, the answer is just buy a second ticket. That'll increase it by 100%. So perception versus reality. You know, things we fear, airliner deaths, are much less frequent than traffic accidents. We're worried about E. coli in beef, but seafood poisoning is much more common. Overweight is a much greater loss of life expectancy than our risks from nuclear energy. And you can see risks of being murdered and killed by falling objects. And patients are terrified of getting a blood transfusion with HIV, but the risk for that is really very, very low. So in our confluence effects now, we have 3 things. The last one, and one that's a little more controversial, is screening mammography and survivorship. And this is something that there's a complicated and controversial literature, but I want to try and throw out a presentation to at least bring these to your attention. So if you read the literature on this, it says most women with screen-detected breast cancer have not had their lives saved by screening. They are instead either diagnosed early, so you find them 3 years before it would have been found clinically, and they appear to live 3 years longer, or they're overdiagnosed. They didn't really have cancer, and they're overdiagnosed. And this graph shows the impact of screening mammography in the United States. Now, a screening program is designed to catch a disease at an early stage so that you can avoid it going on to a late stage. So if you find an increase in early stage breast cancer, which is shown in the blue line, you should see a decline in the late stage disease 10 years later. That's the red line. And in fact, the decline in late stage disease was very modest. It was 8 fewer cases per 100,000 women. The early stage disease, ductal carcinoma, went up by 300%. There was a huge increase, as you can see. The fellow who wrote the paper describing ductal carcinoma in situ did a follow-up paper about 10 years later. He says, "I wish I'd never put the name carcinoma in that word." He said, "I did a survey. I asked women if you would want treatment for breast cancer if you were told you had DCIS versus dysplasia versus abnormal cells. And the likelihood of women wanting treatment for cancer went down dramatically as the wording for the condition changed. So the effects of widespread screening mammography, most people accept that there's been a 20% reduction in breast cancer mortality. The question is it really changing all-cause mortality? Ductal carcinoma in situ has gone up dramatically because of early diagnosis, and not all of these progress to invasive breast cancer. But many women will choose to go on to have post-op radiation because of the fear of cancer. And a 2011 Cochrane review said screening reduces breast cancer mortality, but at the cost of substantial harm from overdiagnosis. And they provide these numbers. So 10,000 women screened from age 50 for 20 years, 43 deaths from breast cancer will be averted, and 3 times that many cancers are overdiagnosed. In other words, women are told they have a cancer when they don't. Now, overdiagnosis causes needless stress, anxiety, unnecessary treatment, and treatment-related complications. This is a paper from New England Journal of Medicine looking at the increased rate of cardiovascular disease in women who had breast cancer on their left side and were irradiated on that side. And this has been replicated in recent surveys and studies. It tends to appear after 5 years, and it goes up after that. Women with pre-existing cardiovascular disease have a much faster increase in cardiovascular disease after chest radiation. And this may be why there is not a decrease in overall mortality, even though breast cancer mortality has gone down. And this is looking at breast cancer and lung cancer, and it's very interesting to see that if you have a right-sided tumor versus a left-sided, your risk of cardiovascular disease goes up, and your risk of lung cancer goes up on the side where you have been radiated. So it's not benign to go through treatment. Now, Gotze has been the biggest advocate for stopping mammography. This was an article in the Canadian Medical Association Journal a couple of years ago, and he's questioning, is it time to stop mammography? I think that would be an overreaction. Anybody that does mammography in the audience will probably want to crucify me for saying this after. But it's the best tool we have at the present time. It's not perfect. What I'm hopeful about is that our new techniques are going to improve. We're now doing mammographic tomosynthesis, and we heard a fantastic presentation at NAMS last year about molecular breast imaging, having more sensitivity and specificity, which may improve our screening technologies. So the approach to the dilemma, which was written up by Blair and Welch, is to mitigate the problem of overdiagnosis. Primary care practitioners, surgeons, oncologists, the public health community will all need the help of our colleagues in mammography. And the first step in addressing any problem is to acknowledge it. So people that are selling mammography as the perfect tool are overselling it, and we need to be realistic with what we tell women. They need accurate information about risks and benefits. They need to know there's a high recall rate and that some people will be overdiagnosed. Now, to follow on this is the whole issue of survivorship. Maureen McTeer in her talk yesterday said we've gone from victims to survivors. And I challenge that a little bit. There's two factors that influence the number of survivors. It's the improved treatment, but it's also the women that are overdiagnosed. If you're told you have breast cancer and you go through treatment, you never had breast cancer, you're a survivor now. And the more people that go through screening, the more enthusiasm there is for it. This has been written up called the popularity paradox. Celebrity endorsements, gee, I shouldn't use Rudy's name in there anymore, for cancer screening. Rudy Giuliani, PSA, and Katie Couric had her colonoscopy on the news, and Christina Applegate and others for mammography. And celebrities carry a lot of weight in our society. Breast cancer survivor stories are generally very simple and persuasive. The headline they have is, "Get tested, get treated, it can save your life, it did mine." And the pink ribbon campaigns are all over the place. This is a football game in the United States. Now, pink ribbon campaigns are good in one context. They play a very important role in empowering women who've had the diagnosis, but unfortunately they've become a widespread marketing ploy. And the Pink Ribbon campaign now is going after everything. This is football stadiums. This is all the merchandising: Kentucky Fried Chicken, Campbell's Soup, cosmetics, jewelry. And there is a book written by a person at my university, Queen's University. It's called Pink Ribbons, Inc., and I encourage you to have a look at it. This is a story of commercialization of the breast cancer movement and the exploitation of human generosity, hope, and trust. So you're being sucked into buying bread because it's got a pink ribbon on the packaging, and very little of that money is going to where you think it's going to go. Now, how about the money? How much they raise? So Susan Komen in the United States has the Susan Komen for the Cure Foundation for breast cancer. And she raised $430 million in 2010. The American Heart Association had Go Red for women, and they raised only $30 million. So the disease that's killing more people is not getting the attention. And women's perception of coronary heart disease is very limited. They believe they're going to die from breast cancer, not from heart disease. I tell physicians when I give this lecture that this is the most important slide I'm going to show you today. If you take 1,000 women, age 40, and you follow them for 10 years, you will have 15 cases of breast cancer diagnosed, and 2 of them will die, and 21 will die from something else. What do you die from at age 40? Leukemia, car accidents, things like that. But as you go down in successive decades, what you see is the deaths, which are mostly cardiovascular, stroke, and heart attack, totally eclipse the deaths from breast cancer. 670 versus 11 over 10 years. And this is something that if you're a family physician and you want to do something for your patient, go after their lipids, blood pressure, that kind of stuff before you even think about mammography. It's much, much more important. So our 4 effects that have all come together to raise fear about breast cancer are shown here. Now, what's been the cost of this misplaced fear? A generation of women have suffered needlessly with vasomotor symptoms. We've substituted alternative therapies, most of which are placebo. There's been widespread use of antidepressants in women, increased genital urinary syndrome of the menopause, increased osteoporosis, and an uncertain long-term impact on cardiovascular disease and cognition, topics that are being discussed at this meeting. This is a publication in the Canadian Medical Association Journal showing the prescription. You see the double lines vertically. That's 2002 when the WHI was reported. The orange line is the sales of selective uptake inhibitors that showed an inverse correlation with the prescription for hormone therapy. And those authors concluded that the simultaneous increase in SSRI prescriptions suggests that they were being prescribed for the psychological and physical symptoms previously controlled by hormone therapy. And they didn't help with bone or they didn't help with vaginal health. Now, this surprised me a little bit. I've been using SSRIs for women who there's a contraindication to estrogen, for people with breast cancer and stuff. This is a network meta-analysis published just a few months ago, systematic review of 47 randomized clinical trials. A network meta-analysis implies that the treatments are not all identical, but they're from the same class. So they're different SSRIs. But they had 8,000 women. And their conclusion was that these are ineffective in relieving vasomotor symptoms, and that women assigned to receive those versus placebo were much more likely to discontinue due to side effects such as low libido and so on. What's the solution? My last 2 or 3 slides. When discussing menopausal hormone therapy, we need to acknowledge the concern about breast cancer, describe the best evidence using absolute numbers. Estrogen alone, there's a possible small increase with longer-term use. Estrogen and progestin, first-time users in WHI showed no increase in the first 5 years. The overall increase, and probably something we need to discuss, is there may be an additional 8 per 10,000, and estrogen plus a SERM is currently unknown. Remind women that bioidentical hormones carry the same risks, that lifestyle factors are equally important for reducing breast cancer risk, and family history of breast cancer, even BRCA mutations, are not a contraindication to HRT based on the best observational data that's available at the present time. These are the lifestyle risks that have been summarized nicely by Singletary, and what you see is the estrogen progestin use at the top is comparable to a lot of other lifestyle factors. Our role as investigators, it's essential that we bring research findings to the awareness of physicians, public, and policymakers in a way that does not exaggerate the findings and distort the truth. This usually will involve using absolute rather than relative benefits and risks. Be aware and declare the difference between associations and causal associations, and it's a delicate balance between getting attention for your research and keeping it real. Our role as clinicians is to bridge the gap in medical knowledge and understanding derived from all the publicly accessible sources, friends, media, internet, the people that market alternative therapies that imply that hormones are dangerous, and advocacy groups with evidence-based, common sense advice. Thank you very much.